Hey, everybody. I can hardly believe we are at class 12 out of 14. Welcome to everybody who is here in the live chat watching live. Welcome to everybody watching in the replay as well. We're having about 150 people or so are watching on the replay very regularly, which is so cool. Today is a big day. We are covering the baby coming out. We talked about the baby inside, and now we're going to talk about those first moments of the baby emerging and baby on the outside. So very great topics today, and we are first actually going to start with the placenta. And if you are on my registration list, you got an email from me today with a heads up that we are doing it a little bit shorter today. I have to make it 45 minutes because I have a prior commitment. But anything that we missed today, or if there's any questions or anything, I will definitely be able to catch up with tomorrow. Tomorrow, we're talking about pain management strategies. We're talking about some pain management topics we haven't covered yet, like IV narcotics, nitrous oxide, and sterile water injections. So that's all tomorrow. And then we're going to talk a lot about sort of layering up and making pain management decisions. So tomorrow's a great class, but it's also kind of my buffer class so that if I need some time to round out some of our topics, we have time to do that. So I love seeing all of my familiar faces. We've got Bridget and Kayla and Christy and Anne in the chat. I love it. If you have been watching live and you haven't been active in the chat, today's a great day just to hang out. Get your question in the chat. Just say hello before we get started. That would be great too. Okay, so 45 minutes. They're going to be nice and busy. And we are going to get it going. I just really can't believe we have 3 more classes. That is so wild, right? Hello, Marlena, and hello, Elizabeth. Hello, hello. Okay, I want to kind of start with this chain of events. And we're going to go a little bit back and forth as we go through this in depth. So don't feel like we might feel a little bit, we're going to go through this chain of events, but we're also going to expand on some. So first I'm going to go through the chain of events, and then, I'm going to pull out. I just said that twice. What is up with me? It's like I'm worried about the 45 minutes and I'm trying to get it all in. Welcome back, Quinn Vlog. Welcome back, and hello to Altair. So chain of events at the end of pushing. Let me grab baby. Baby's still in the pelvis from last night. So here we are. When last we left baby, when we were pushing a couple classes ago, I believe we talked about up until baby is about at the crowning phase. And I said that I was going to cover more in depth about that crowning phase and about baby coming out. So first of all, I know I touched on it a little bit, but perineal massage. And so perineal massage is the idea that before we have our baby, that we spend some time stretching and massaging our perineum. So if that is something that sounds like you would want to do, you would want to use some type of lubrication or oil, and you would stretch your perineum, kind of stretch back and forth, and you would do it regularly for like 5 minutes. Now, a lot of people have their different theories and that kind of thing on it. And I'm going to give you mine. So take with it whatever, you want. But I will say that the research says if you've already had a baby vaginally, it's not useful. It's not doesn't improve the risk or reduce the risk of tearing. And really that's the goal, reduce the risk of tearing, to do perineal massage before the birth. So you're 36 weeks, and on. There is some, oh, good. Thank you, Kayla. Sarah Levon has some great videos on perineal massage. That's great. I do not have any videos. I'm kind of mixed on it. it's kind of my opinion that the body works really well and that we shouldn't have to prep our body to give birth because our body kind of already knows what to do. So that kind of like stretching to me feels a little bit like, do we really need to do that? Doesn't the body work the way it works? But I'm not against it or anything. But to me, it feels like, meh, I don't know. Especially when I've had people who say they just dread doing it and it's uncomfortable. I'd rather you spend time talking to your provider about supporting your perineum or using warm washcloths. That to me is a lot more important than the perineal massage. So let's talk about those two items. As the baby is stretching, crowning, baby's at the very widest part of their head, that is when the tissue there stretches to a point where people can experience what's called the ring of fire. So it's usually a burning sensation that is short and then it stops. And then this tissue is like a natural numb that happens, numbing out that after the ring of fire. So as if someone has a baby and experiences a tear, they don't feel that tear. They might feel an intense sensation, but it's not like, oh, I know that I tore. And people always ask me, did I tear? Did I tear? Or ask their provider, did I tear? And the provider always says, I'm not sure. I need to check after, we get the placenta out and that kind of thing. Or they might have noticed a tear, but they don't know the extent of it. So at this moment, what is helpful is if the provider, so I'm going to put this, my hand here is going to be the perineum. This hand is the provider, okay? So if your provider takes their hand, their gloved hand, either with a wet, warm washcloth or just their hand, and as the baby is bulging that skin out, they actually put their hand on this skin and support it. So what that's doing is it is preventing the skin to be sort of overly pushed out. And it's almost like an art. I usually see midwives more than doctors that are very careful about trying to help prevent a tear. And it's almost like they're like, okay, give me a little push. Okay, a little push. And that perineal support makes all the difference in that, supporting that tissue so that it can help prevent or lessen tears. And I have had the benefit of seeing a lot of different providers, both very hands-on and very hands-off. And the very hands-off providers, instead of doing this, like, okay, they just have their gloves and they wait for the baby's head to pop out. And then they put their hands up and help baby up, which is so different. It is so different than that support. And supporting is what we want. And so on your list that you're making questions for your provider, please add that question, or I recommend you ask that question. Do they support your perineum during pushing? Or you could say it open-ended, like, what do you recommend, or how do you recommend that people reduce their likelihood of tears? So that allows them to say something like, well, I support the perineum, or I help coach you to not, try not to take a big push at the end. Or they might say something like, oh, sideline position is good. I could do a warm washcloth. Or they might just say, I don't do anything. So if they say, I don't do anything, you could say, oh, yes, Marlena, questions. She said, do we just tell the doctor, like, can you please support my perineum? How do we ask? That is absolutely how you ask. But you know what, Marlena? I would ask that question of the nurse. Like, when you start pushing in those breaks in the beginning, ask it in the beginning. Like, hey, I really want support of my perineum. I learned that that's a way to help reduce tearing. Can you help me facilitate that? Or should I ask the doctor? How do you, ask your nurse, like, how should I go about asking the doctor? Because if the doctor comes in your last like 3 pushes, which sometimes happens, or the midwife might come in, late too, depending upon if they have other clients, other patients. You definitely ask like that. Now, in my email, if you guys got it today, I sent a link to those birth vlogs to watch. Okay, let me know in the chat, yes or no, if you have had a chance to watch my video about 5 birth vlogs to watch. Because in that video, it's the last birth vlog. Megan Acuna, I think is her last name. She says during her pushing phase, in between her push, she says, could someone get a warm washcloth or warm compress, please? And it's a perfect example of like how you can advocate for yourself in that time that's pretty sensitive and like you're about to, meet your baby. And I love that example. It's such a great example of, and of course, partners can do that too, can ask that question too, either person, but it's a really good, okay, good, you guys. Yes, you guys have started watching it. Quinn says, I'm afraid to. So I think I understand that you might be afraid to, Quinn, but do know that I try to pick really good birth vlogs that aren't scary. Anne started it. Okay. Marlena said, I didn't yet, but you're making me want to watch it after this. Perfect. Well, we're getting done 15 minutes early. So that is a perfect assignment for you guys to watch because you'll see her advocate at the end. And I pointed out and I put a little speech bubble so that you won't miss it. In my version, you can go back and watch her whole birth, which I highly recommend, her whole birth vlog as well. But I point out, I clip that and show that one piece. Okay, so supporting the perineum is helpful. And the baby, if baby is coming out not OP, if baby is coming out the easier way, OA, they're coming out where they're face down. And as they start emerging, they will turn and come out shoulders and then up. Okay. So baby is out. Now, here's the thing that and in the playlist for tonight, I have a couple of videos about skin to skin. And this is a topic that it is hard for me to talk about because it makes me very ranty and passionate, is that it's so clear. It's just crystal clear that the best thing for baby is to be skin to skin. Skin to skin, no clothes here, no clothes, no blankets, nothing, naked like this and a blanket over you. But it is still not done like this regularly. So partners, this is a great thing for you to be ready to promote skin to skin. So if baby is about to come out and, there's something that your partner is wearing that you can unbutton, like if you were in a hospital gown, you can unbutton the sides so that you can pull it off. If you're in a t-shirt, take it off. If you're in a bra, take it off, pull it up, whatever to do, pull it up. If a nurse plops a towel down over your bare skin, move it and say, I want skin to skin. If they say, I need to dry off baby, no, they can dry off baby skin to skin. You can be skin to skin and they can just dry and they can dry baby. That is what we don't want. And I've seen it so many times is the towel to come up, then put a towel on, put the baby over it, and then put a towel over both of you. Well, baby is in a towel sandwich. That's not skin to skin. No. So it is so critical. So watch those videos because they are going to go into detail on that particular stage. And if you guys have questions about it after you watch that skin to skin video, the one with the baby on it, we can talk about it tomorrow because I'm very, very passionate about this topic. Okay, let me answer Elizabeth's question. Excuse me, I feel a little scratchy. Can you do skin to skin after C-section? I didn't answer that last night. It's a great question. You can, as long as you have an advocate for you in the in the OR. So if you had a unscheduled C-section, so it went from a labor to a cesarean birth, you would want to say to your nurse, like, hey, can you make sure and help, or I really would want to do skin to skin as soon as possible in the OR. And what happens is they would help. So if you're laying down, they would help put baby here, skin to skin on you. And usually you're a partner who's there or a nurse. Someone has to help hold baby up there because you might not have like your hands free or feel comfortable. But yes, skin to skin is possible, but you have to advocate for it. You have to be strong and say, this is really important to me, because I've seen it work really well. And I've seen also people, nurses just kind of blow it off and say, oh yeah, we can do that. And then they wrap baby up and then put baby like that. Or they let skin to skin with partners in the OR also, which is great. And skin to skin with partners is still very, very good for baby. So that is another option if for some reason you couldn't be skin to skin in the OR. Yes, Marlena, I am totally with you. 9 months. And that's skin to skin. That first time you feel baby, I mean, to me, it is a feeling that I will never forget. That first touch of that warm, kind of wet skin. It is really, really cool. Very cool. So skin to skin. And I put on there, no distress, no meconium. Yes. So that is if baby was born and they immediately are looking at the baby and they're giving like some quick scores called APGAR scores. If they see a baby that doesn't look like they're breathing yet, if they look at the muscle tone and the baby is floppy, that is a concern that they would probably do a quick cut of the cord and bring baby over to the warmer to, get extra help breathing and whatever the baby might need. So if there is an issue that they can tell right away with the baby, there wouldn't even be a time to have a conversation about anything, cutting the cord or anything. They just bring the baby over. So, and then meconium is kind of I was going to say a gray area or a green area, kind of, where if the meconium, so baby had their first poop in the womb, if it is light, so it's not that much, that might not be an issue. If the baby had thick meconium, they would likely cut the cord soon after, right after the baby came out, take the baby to the warmer, sort of wipe baby off, maybe even do some suctioning to make sure baby doesn't breathe in that meconium. And so that skin to skin could happen. And we're going to talk. Yes, good question. Okay, we've got lots of questions. Bridget, yes, partner looking forward to skin. I love it. Absolutely. Very, very good. Yes. So plan to wear a button down or a shirt with easy access. So this is interesting. So not interesting, something to remember. And Bridget and anybody else who's watching, whether you are a female partner or a male partner, you should have the right and ability to be completely topless, skin to skin with your baby. And I have heard sometimes female partners have had some struggles with that. So no, that's not acceptable. Partners, skin to skin, topless, that can work. Now, if you feel more comfortable wearing a button-down shirt that you can kind of tuck baby in, yes, whether you are male or female and you feel more comfortable that way, that's a great tip. But you should be able to just topless and put baby on you. Okay. Elizabeth said, what are the negative effects if you aren't able to get skin to skin? So what happens with babies skin to skin is the research has been so clear that babies regulate themselves better when they are skin to skin. So their temperature regulates better, their breathing regulates, and their blood sugar regulates, which is, to me, what is so crazy. Like, seriously? How? Just because you're holding. So negative effects could be the baby does not transition into, it has a slower time to transition, which means more time separate from you. And so like any kind of procedures or anything in the beginning, as much as they can be done skin to skin, that is really the way they should be doing it. But if baby is not doing well, of course, we want baby to first get to a spot where they are healthy enough and doing well enough that we can do skin to skin. That's a great question. Bridget says, can skin to skin happen with delayed cord clamping? Absolutely. And I'm going to talk about delayed cord clamping more next. Would a sports bra that zips in the front work? Absolutely. Love a sports bra that zips in the front. So much better than a sports bra that doesn't. Because, you know, when you're wet and sweaty, which a lot of people are once they're done pushing, trying to get a sports bra off, man, that is like might as well be a straight jacket, right? Just like raw. That's hard. Yes, you can do. Okay. I love it. Kayla, that was good. Bridget said, my wife says, what's one more pair of boobs out in the room? Yeah. I mean, unless obviously you feel uncomfortable with them out, but exactly. Right. I mean, the nurses, the healthcare providers shouldn't care. Hello. I love that, but I have heard some challenges sometimes. Okay. How long should skin to skin be? Skin to skin, that process should be at least an hour, that golden hour, right? Golden hour. I love it. You guys are awesome. Okay. So skin to skin, let's talk about cord cutting. Cord cutting. So the baby, has the cord. So if baby has for some reason has a short cord, and so I'm having a hard time putting the cord back on the baby. There we go. If the baby has a short cord, just born with a short cord, baby will only be able to go up to, won't be able to come up all the way here because the cord won't be long enough. So if the baby's short cord, they might just put baby here until you cut the cord. Okay, so they might say, oh, baby's got a short cord. Also, just real quick about the cord, I think it's around 30 or 40% of babies do have the cord around their neck at birth. And providers, as the baby's head comes out and they see a cord, let me see if I can just, right there. They just take their finger and unloop it as baby comes out. And it's usually not an issue at all. A lot of people, I guess the idea of it is very concerning, but it's easy. And if the cord for some reason was tight, they would cut it right there at the perineum. I've seen that once, but not common. But common, they call it a nuchal cord or a cord around the neck. I remember my first born was born with that cord, and both my mom and my mother-in-law were there for the birth, which is just so hard for me to believe that they were there, because now we have no visitors allowed, right? But they both were so scared when the doctor said there's a cord around the neck. They were like, oh, and then of course, it wasn't an issue at all. So take the cord. And then the cord cutting, yes, there's a good question here. Patty says, is cord clamping the same as cutting? It is the same. It's not the same activity, but it has the same result. So what they will do is clamp the cord with this like a metal clamp, and put 2, and then you cut in between the 2 clamps. As soon as they clamp the cord, it might as well be cut. It's like, it stops the blood flow. It doesn't, oh, Kayla is my assistant. I'm so glad that you're in the chat. That's helpful. So now I have a couple slides. We're just going to go back. We're going to talk about this delayed cord clamping right now. So this is directly from the American College of OBGYNs. Okay. And in term infants, so infants that are 37 weeks and up, delayed umbilical cord clamping increases hemoglobin levels at birth, improves iron stores in the first several months of life, which may have favorable outcomes, developmental outcomes. So favorable on how the baby develops, right? That's pretty significant. And then they go on to say, given the benefits to most newborns and concordant with other professional organizations, the American College of OBGYNs recommends delayed clamping if they're vigorous. So if they are doing well after 30 to 60 seconds. So if you're thinking, wow, 30 to 60 seconds, that doesn't seem long. That's how I feel too. 30 to 60 seconds is not very long, though it is longer than it used to be. It used to be baby comes out, doctor reaches over, clamps the cord, puts baby on, mom grabs the scissors, who wants to cut the cord, whoever's cutting the cord cuts it, and then it's done. And that's within like 3 minutes. So you actually can request any amount of time that you want. And I'm just going to give a number. Like a lot of educators and midwives say around 3 minutes, that the baby's 3 to 5 minutes, we see less of the blood sort of going either to the baby or to the placenta. Yes. Did I miss questions? Yes, Melissa, I am with you. No whisking baby away to a nursery for tests. No, nothing has to, all the tests and everything should be able to be done with you, baby, on your skin or in the room for sure. I like that. You made a good decision there. Patty said, I've heard one drawback to delayed clamping is a greater risk for jaundice, since I think, at high risk for this already because of ABO compatibility. Would that be a reason not to do it? I don't think that is, I would talk to your provider, but I would say a 30-second delay is not something that is going to increase your risk of jaundice, your baby's risk of jaundice. But I would talk to them about it. Yes. And then Anne, this is another option. Anne says she doesn't want to cut the cord until the cord stops pulsating. So if you actually feel the cord, you can feel it, a pulse in it, just like, the pulse in your artery. And you can feel it. So you could always say, can I feel the cord before I cut it? Or can we wait a couple more minutes? Or talking to them before. Did I block the right person? Okay, good. Bridget, I thought I accidentally blocked you. That would have been bad. I was reaching up. So it's totally up to you on what is your preference. But what's cool, and not that this is a visual that, I guess this is pretty accurate actually. You guys can kind of see it's about the width of my finger, right? And that is about what the cord is like, maybe like a pinky finger when it's nice and filled with blood. And then after it stops pulsating and the blood either goes to the baby or to the placenta. So right before you'll see the cord change. And if you waited long enough, it would look just like a flat straw. It looks almost like a clear flat straw. Sometimes at a home birth, we see a more significant delay, like an hour or something like that. And it just changes so dramatically. It just collapses and is like a straw. I mean, of course, I think it's amazing, just the way it works. But okay, whoever wants to cut the cord can. Don't feel pressure if you don't want to from a nurse or care provider. I have seen providers pressure partners into cutting it. It's totally up to you, whatever. Kayla said it looked like a tapeworm at the end. Yes, that is a weird visual, but it does, like a collapsed straw tapeworm. So cord cutting, that is the cord cutting and clamping. So you're holding baby, placenta is still inside of you, cord is still going inside of your vagina, and placenta is still in there too. Now, within the first about 5 to 15 minutes ish, sometimes longer, especially with the home birth, they tend to just kind of chill out and let the placenta come on its own. Sometimes at a hospital birth, they are more wanting the placenta to come out quicker because it's like one next step closer to everybody safe and healthy. So sometimes we see that rushed a little bit, and I'll talk about that in a little more detail in a second. But 5 to 15 minutes, the placenta will separate. So the placenta will separate from the uterine wall, and then it will usually just kind of fall down sort of to the cervix. And at that time, if you are unmedicated or you have a very light epidural, you might feel the need to push again. And sometimes people are like, oh my gosh, I sort of need to push. And it's like, what's going on? Why? I thought it was over. Do I really have to push again? And birthing this is so much easier than birthing this. So sometimes I'll hear midwives or doctors say, just give me a big cough, a few big coughs, or a little bit of a bear down, and then the placenta comes out. So what research says about the placenta is that we can give gentle traction on it, kind of tug to feel like, has it let go or not? But we shouldn't see aggressive pulling. Aggressive pulling on the cord and the placenta can lead to retained placenta, and retained placenta is a serious complication, especially if it goes unnoticed. And what happens is the body still thinks, oh, there's still a pregnancy, and those hormones from the placenta are still being emitted into the body. And we see a delay in milk, mature milk, milk changing, milk coming in. So we don't want that. Yes, Marlena says, is the placenta right now to scale with the baby? Yes, this placenta is definitely to scale. Here, let me take off my slides. So here's baby, here's placenta. Absolutely. Now, placentas are grown in all different sizes. I've seen people with placentas that are half this size, but I have seen placentas that are even bigger than that. So it is, it just depends. Also cords, like I said, some cords can be really, really long. Sometimes they're short. It's just very cool, how that happens. And it's really cool if you want to see it afterwards, you can ask your provider, like, hey, can you show me the placenta before you send it away? Or if you want to take it with you, to either have it encapsulated or to like bury it in your backyard and plant a tree over it or something like that. There are different things that people do with the placenta. So you might have that option too. Okay. And let's see. Oh, Diana says, what makes the placenta pulse, the baby's heart or the mom's? So it's the mom's. So it's still, what's happening is the blood flow is still coming from the uterus. So the placenta and the uterus they're attached before it comes out. And then that pulsing that happens to help the baby get oxygenated, that is what's still happening with the cord when baby's born. It's really cool. You know what, Christy? I wish I was more educated to tell you that. I actually don't know. I know it depends on what type of twins and if they're sharing a placenta and all that kind of stuff. But I don't know the answer to you about delayed cord clamping with twins. I think they can. But of course, you have to have a provider that's, ready. Diana, Radio Lab podcast about the placenta. Very cool. I would love to see that. If you want to share that link with me or email me, I can share it here or later, or you can share it obviously in the chat too, but we can Google it probably. Okay, let's see. Where am I? So what we don't want to see is aggressive pulling of the placenta. Okay. So if we notice that, providers, you might say something like, not providers, partners, you might say something like, oh, is the placenta ready to come out? Right? Kind of to bring note of like, oh, is the placenta ready to come out? Right? I would also talk to your provider about what's their theory on the placenta. And just, we don't want that manual tugging. That's not great. Okay. What else? If you have a tear, a repair will be done after the placenta comes out. And if you don't have an epidural or your epidural is too light, they will give local medicine. So they will be giving medicine so that you don't feel any kind of stitches. And that repair sometimes can take a while. Sometimes I hear people say, how many stitches did I get? They don't count the stitches. It's usually like a continuous stitch. So I would just say, let them take their time on the repair and you focus on holding that baby, skin to skin, holding that baby. Great question, Anne. Yes, absolutely. At a home birth, the midwife will do all the stitching if any stitching is needed. If there was a need, if the baby got to right here and their baby, or let's say here, where you can see the baby's head, but for whatever reason, there is no movement, like with the contraction, pushing, we're not getting baby past that last sort of final push, or baby, all of a sudden heart rate just goes down and needs to be born quickly. Either depends on how close baby is to exit. If baby is more like this, a little further back, your provider might suggest a vacuum extraction or forceps. Very unlikely forceps because people just aren't trained on forceps anymore. And a vacuum extraction is like a suction cup that they put into your vagina on the baby's head. And then as you push, the provider pulls on the suction cup to help assist that last birth, that last push. And I know that that's probably sounds like a lot, like an aggressive, like maybe not great for baby. But on the flip side, a baby who is that far down the birth canal and that close to a vaginal birth, if we stopped and we went to a cesarean birth, which sometimes happens, sometimes there's a need, but if not, if we need to go to a cesarean, the cesarean is actually also going to be a lot of pulling and rough on the baby. So it is because baby is so far down through the pelvis, they do, and I've seen it, a lot of aggressive pulling on the baby in the cesarean. So sometimes people say, well, I don't want the vacuum because I'd rather just have a cesarean, just, to do a surgery, take baby out. I don't want the baby to have to go through that, but it is pulling either way. Okay. So it is either way, it's this intense kind of it's an intense moment if baby needs to be that way. Okay. I've got to take a second and look at the bots. Thank you, Johnny. I should like block the user. Okay. So what question do I have? Nathan's taking my baby. Okay. So Bridget,
hit the like button.
I don't have much
if
time
you hit
today.
the like button, I might return the baby.
Okay. Nathan says, hit the like button and then he'll bring the baby back. Okay. So Bridget says, what do people do with the placenta? Someone told me about training cadaver dogs. Yes. In some cities, they have that. Some people dehydrate it or have it done, encapsulate it and put it in pills. And there's no definitive research about it helping either way. So that's why I don't give you much more information. I'm kind of putting that out there on your own for research. Patty said, have you ever seen husband stitch or bad stitch practices done? You know, I have not ever seen anything close to that. Oh, thank you, Nathan. I have not seen anything close to that, even though I feel like I still hear that sometimes from people reporting that. But I feel like that hopefully has kind of gone by the wayside. Yes. Okay. Okay. Oh, risks of vacuum extraction. There are some risks of swelling on the baby's head. That is, I would say, the most common side effect, that the baby might have kind of like a swollen section, fluid on their head. And that is one of the main risks. Yes. Yep. Okay. How are we? We have like 5 to 10 minutes. Let me go back to my slides. I talk too much, guys. It's hard for me to make it short. Okay, we talked about placenta. Pitocin is which most hospitals, their policy is to give Pitocin in a bag via the IV to help, like a safety net of postpartum hemorrhage, to help prevent postpartum hemorrhage. So it helps the uterus clamp down. It is not done at home births, and unless there's some kind of problem, and it's not done at birth centers a lot of times. So it's more of a hospital thing. And there isn't really much of a risk besides the fact that you have to have the fluid and the placenta, fluid and the Pitocin at the same time. So that you're getting extra fluid. So it is something to know. And then Pitocin, yes, repair of the perineum. We talked about that. And then let's talk about this scene change. And oh my gosh, right? I can't stop. There's so much to cover. The scene change. We already talked about 2 scene changes, right? The scene change of it's time to push, and the scene change that you might have of time to change from laboring to a cesarean, right? This scene change is the most exciting, I think, scene change, because it's where everything starts getting quiet and you have time with baby. So this is where is like the sweetest, like coolest thing, and also might be very uncomfortable and weird. So I like to just cover that when you have had a baby on the inside for 9 months and all of a sudden it's here, your brain sometimes goes through this moment of like, what the heck just happened? And I've seen people, instead of some of those pictures or videos where we see babies, where we see that right, that like, oh my gosh, which is lovely and perfectly acceptable, but there might be a look of like, what? Huh? Whoa, what's going on? So partners, just be aware of that. I remember the first time I saw one of my clients kind of have this look, I thought, oh no, like she's not happy about her baby. Like, what's going on? She just had a baby. Isn't she happy? And then I realized, oh, yeah, she's just trying to process what the heck just happened. Okay. I recommend if you have your, I was going to say, if you have your phone, take your phone and partners, turn it on and get a little short video of baby doing their first cry. You're never going to hear that sound exactly the same way again. So take all the pictures that you can, but also experience it. If you have a doula, let them take 1,000,000 pictures, because you'll never regret having those pictures. But you are going to want to just be with baby. Do not feel like as soon as the baby comes out, I need to start breastfeeding. I need to breastfeed as soon as possible. That's okay. Like, just allow baby to kind of settle and have some time for a minute. You will start looking for cues, for hunger cues. You'll start looking for them to, root, where if you touch their cheek, they're like, where's the breast? Or they start sticking their tongue out. That means that it's a great time to put them close to the breast and see if you can, gently get them to latch, or allow them to try to latch themselves. Both, I would try both. Allow them to put them close, see if they'll latch, or try to latch themselves. Okay. So since this is not a breastfeeding class, I'm just giving you sort of a very high level, but use your resources at the hospital. Okay. I am got that. This is a huge takeaway. And I'm going to talk for about 3 more minutes. If you don't remember anything today, it's your baby. So you have to start advocating for your baby as soon as, now when baby is inside. I would love for you to start, if you haven't started thinking that you're your baby's healthcare advocate. But just think, if you put your if you put your mind like to their 6-month appointment and your doctor suggests something that you don't feel comfortable with, you're going to speak out. It's going to be easy because that's your baby. 6 months, you've had this baby for 6 months. Of course, you're going to be like, I don't think I feel right about that. So try to channel that. If for some reason, say you're holding baby for skin to skin and they say, oh, we want to take the baby in, get the baby weighed, and you've only been holding your baby for 15 minutes. That's when you want to say, no, it's my baby. And one of the things that mantra I want you to remember, the dance is what you'll be doing with breastfeeding, each partner learning to dance. Oops. Oh, eat all the food and drink all the water. I'm missing a slide. Where's my slide? Here's my slide. The wait can wait. For whatever reason, healthcare providers love to say, let's go ahead and weigh the baby. Do you want to see how much the baby weighs? We don't need to weigh the baby in that first hour. That first hour is so important, so important. And anything they want to take baby from you to put baby somewhere else and do anything and whatever, I really want to strongly recommend for you to say, hey, can we do that right here on our chest? That's really where I want that to be held. Okay. So we talked about the first 40 minutes. It's like a dance. Even if you've breastfed other babies, you've never breastfed this baby. So it still might be a new activity that you have to learn. And then please, as soon as you can, eat all the food you can and drink all the water you can. You just went through a marathon. Partners, you too. You were allowed to eat all the food and drink all the water as well. So don't delay in starting to get food into your system. It's also, the sooner you eat something, usually you can have ibuprofen, which even if you've gone unmedicated, ibuprofen is really good for those postpartum aches and pains. Okay. So unfortunately, I'm going to wrap up, and we didn't get to massage or our 30 seconds. So we're going to do our 30 seconds because I cannot leave you without 30 seconds. But what we're going to do tomorrow is I'm going to start with this with massage because we cannot skip adding a tool to our toolbox. So today, just 30 seconds, if Bridget, when does baby get a diaper? I don't really want to be peed on. You can get a diaper pretty soon, but I'm just going to say you are going to likely get peed on in your life. I'm the bearer of bad news. Baby pee is so much like water because they haven't had any kind of food. So it's just like nothing. But I understand. You can get a diaper pretty quick. Guys, thank you for dealing with me and my quick class today. We are going to catch up tomorrow. If you feel like, oh, I have questions, then make note of them, write them down, leave them in the chat, send me a message, leave a comment below, any way you want to get your questions to me, and I'll make sure that I cover them tomorrow. Okay? Great. So we're going to do our 30-second practice because we have a streak and we're not going to miss it. So let's do 30 seconds right now. Okay, guys, we talked a lot about baby and we did it quickly, but if you have lingering questions, I'll get to them tomorrow. And of course, massage, we ready. But your homework, since you have 15 extra minutes, make sure you watch this week's playlist because we do cover massage or homework. We do cover massage in that, and I want you to see that. And check out the skin to skin and the birth vlogs that I recommend, that video on my channel. Okay. Okay, guys. See you tomorrow. Gotta run. Bye.